Welcome to the ISTH Gene Therapy for Hemophilia monthly update. This update is part of an ISTH comprehensive educational resource designed by leading experts for the global hemophilia community to help you stay abreast of the evolving science and latest clinical advancements in gene therapy in hemophilia.
Hello, my name is Guy Young. I'm a pediatric hematologist by training, although I do take care of children and adults with hemophilia. I'm the director of the Hemophilia Treatment Center at Children's Hospital Los Angeles, and I'm also a professor of pediatrics at the University of Southern California Keck School of Medicine. Thanks for participating today and listening into this session about a question and answer session revolving around gene therapy. We're going to talk today about hepatotoxicity with respect to gene therapy. So what do we know about gene therapy thus far? We're using an AAV-based platform, although other platforms may be coming in the future, where we are transfecting hepatocytes with transgenes that are made for both factor VIII and for factor IX. So since we are inducing a transfection using really large amounts of virus, I mean, the viral loads that patients are receiving with this AAV are really quite staggering. In fact, doses ranging from 10 to the 13th up to 10 to the 15th viral units or vector genomes, as we call them, which is a really large amount of viral expression going into the liver. Now, we need to do that because probably a lot of this product is lost during the process of transfection and also during the process of getting the DNA into exactly where we want it and how we want it. And so as a result, all of that virus coming into the liver may create issues of hepatotoxicity. And the hepatotoxicity issues can fall into a few categories. One is a direct toxicity as a result of the product and the virus going in there. The second would be an immune response against the viral vector, the capsid, that may cause hepatotoxicity. And the third would be related to what we call, basically carcinogenicity. What is the risk that the DNA will end up integrated somehow into the chromosomes and integrated into an incorrect area where we have a hepatic promoter? If you put a hepatic promoter next to an oncogene, could that somehow trigger malignancy? So those are the three categories: direct toxicity, immunological toxicity, and carcinogenicity, as I think of it. As far as direct toxicity is concerned, we do see elevations in the transaminases in many patients after getting gene therapy. Now, this could be direct toxicity, or it could be also an immune response. Considering that the elevations in the transaminases take some weeks often to develop, we think it's probably more immune-mediated. In other words, the immune system is recognizing hepatocytes that have been transfected, hepatocytes that have pieces of the viral capsid that is being expressed on their surface. And essentially, the body's immune system says, hey, my liver's gotten infected with AAV. Let me go in there and basically kill off those hepatocytes so I can get rid of that virus. That's essentially the simple way of thinking about this immunological mediated toxicity. Now, thankfully, no patients have had severe hepatitis from any of the gene therapies. No patients have had liver damage as a result of the gene therapies. But the toxicity is probably more related to the efficacy, meaning that this hepatotoxicity may result in loss of factor VIII expression because the cells that have been transfected are the ones selectively targeted by the immune system. So let's move on to perhaps the next part, which is the most important part. What about long-term risk? What about the risk for carcinogenicity? You may be aware that in the uniQure trial that was recently presented at the American Society of Hematology meeting, that following that, there was public presentation of a case of hepatocellular carcinoma in that trial. That patient was an older patient. That patient had had a history of hepatitis C for many, many decades, or several decades until he got treatment. So the point I'm making is that you have a patient who was definitely at risk for hepatocellular carcinoma with or without the gene therapy. However, it is concerning that a patient on a gene therapy trial, within about a year of getting the gene therapy, developed hepatocellular carcinoma. Is it linked? Is that linked to the gene therapy? So of course, that's the million-dollar question. And we don't have the answer right now as to whether it is connected in any way to the gene therapy. I'm very confident that uniQure has embarked on some very detailed and hopefully elegant investigations that can give us an answer at some point in the not too distant future about whether they believe that this gene therapy somehow triggered the hepatocellular carcinoma, or hopefully a better answer, which is that they can prove or at least give us strong evidence that it's not related, and that this patient's hepatocellular carcinoma was simply due to the natural history of their illness. Moving forward, we've got a lot of other gene therapy trials in the works. We have to continue to monitor these patients for liver toxicity, both early and late, as well as hepatocellular carcinoma. Which brings me to the topic of moving on from AAV gene therapy. There was a question about, are we always going to just do gene therapy via AAV? And I think the answer to that is no. I think AAV is the first platform. It's a platform that's being used in all of the human trials right now. However, quite soon, there will be trials using other viral vectors, such as lentiviruses. There will also be trials using non-viral vectors, or non-viral transport, I should say, using things such as lipid nanoparticles. And we also have the possibility of having gene editing in the future. There are obviously going to be a lot of questions around all of those areas, and the questions regarding hepatotoxicity may in fact be related to whether we continue to use very large doses of a virus like AAV, or whether we're using lower doses of viruses such as lentivirus, or whether we are using non-viral vectors that may have no hepatotoxicity, may have no immunologic response. And of course, the issue of carcinogenicity long-term has to be front and center, something we need to be thoughtful about, but hopefully not see actually occurring with any of the different platforms that we might use. So anyway, a lot to learn about gene therapy. I definitely encourage you to read more about the hepatotoxicity issue, because it is an important one when it comes to gene therapy. Thanks for listening, and have a good day.